Good morning, friends. This is Dr. K.S. Vivekanandan, your psychiatry faculty for Dr. Bhatia Medical Institute, e-Gurukul. Now we are going to go for the clinical related discussion questions, where there will be a lot of clinical related scenarios, and from which there will be choices from which you have to answer. Now, why is this different? Because what happens is that whenever we face an exam, whenever we see a clinical related scenario, usually it will be like a paragraph question. Now, what happens is that the first thing that you do is when you read a very well, it's all playing with the mind, right? What happens is that when an examiner asks a paragraph related question, it means that he's inculcating some fear. So basically, what happens is the first thing you will see is let me answer it later, or it might be a difficult question. So basically, they are trying to inculcate some fear. So basically, what happens is that I basically feel that clinical related scenario question is a question where an examiner puts his heart and soul to give his best, to act, to give all possible points related to the concepts, so that the student does not like get confused, or the student gets to clarity if he has read it properly. So the best way to assess your knowledge of non-concepts is clinical related questions. So with this small introduction, I'll go into the questions that we are going to ask. I'll slowly read the question and also give the choices, and then we'll discuss. Okay, please concentrate here. A 67-year-old female, okay, it's a female, undergoing treatment for meningitis. Meningitis means what? One organic infection is there. Suddenly starts shouting, "They will kill me today. They are all going to kill me. Somebody is hurting me." On asking me where she is, she replies, "I am trapped in a flight that has been hijacked." Okay. Yes. She appears disoriented. That's a very important point. And there is an altered level of consciousness, which is a neurotransmitter commonly described in this condition. This is very, 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 very characteristic features. This is a very favorite question for examiners. I want you to concentrate. Now, for this, you should know what is the diagnosis. Okay, I'll tell the answer and then I'll go for the description. Here they are talking about altered sensorium clouding of consciousness. So they are talking about delirium, and they want to know whether you know any neurotransmitter that is concerned with delirium. The answer is acetylcholine. Answer is acetylcholine. That is the answer here. But what you should know about how to answer this with confidence is that first and foremost, whenever there is a question that is asked, please look into certain points. That is whether there is words called as altered sensorium. Okay. Or go for the points called as clouding of consciousness. Or go for disorientation to time, place, and person. Attention and concentration impairment. Acute confusional state. Does not happen for a long time. It's acute. And very, very, very importantly, they will have visual hallucinations. Okay. When you know that this is all which describes the entity called as delirium. Okay, this is all nothing but it describes the entity called as delirium. You'll be able to confidently answer this question, because when there is the person is having altered sensorium, clouding of consciousness, disorientation, time, place, and person, attention, concentration problem, it means that they are talking about delirium. See here, there are words like the person is disoriented. Okay, this is a catchy word. Okay, this is a catchy word. And the person, they are waiting to, they will kill me today. Yes. And suddenly starts. Suddenly means what? Acute and onset. Yes, yes. These are the things which is favors towards the diagnosis of delirium. Now, the neurotransmitter that is concerned for delirium is, okay. I'll just put a small important words. Please concentrate. Usually, the neurotransmitter that is concerned with depression. Okay, there is a favorite question that is asked. Depression will be most researched is serotonin. Okay, serotonin deficiency. Yes, the neurotransmitter that is concerned with schizophrenia. Schizophrenia is, I think you all know the answer, dopamine excess. More specific, dopamine excess in the mesolimbic pathway, but it's out of the context now. Just I understand the dopamine excess. And very importantly, delirium. Delirium means the acetylcholine. The pathology in the acetylcholine. Okay. Is a one which is considered to be the pathology for delirium. So the answer is right. I want to add some extra points in this delirium lesson because it is very favorite for examiners. What is it? Is that what are the predisposing factors? Who are more prone for delirium? Anybody can tell me this answer? A old male who's using substance with the dementia, okay, are more prone. And very importantly, when they are not mobile, they're immobile, like they are not able to go out, and like what is it, the physical mobility is a problem. Or very importantly, they have sensory impairment like visual impairment or auditory impairment this makes a person predisposed to delirium. Okay, so I have a patient who's having all these factors, but what makes a person with these factors get it? That is what is called as precipitating factors. Can anybody tell me what are the precipitating factors for delirium? Precipitating factors. Okay, all the person who's a old alcoholic dementia patient and a male who's having sensory impairment or who's not able to move. How when does a problem exaggerate? Please concentrate as given here. If there is any brain insult, it can be a CVA, it can be an infection. The person is having a heart failure, CCF. The person is having lung pathology, pulmonary embolism, or any pulmonary pathology, maybe organic pathology. That's what they're asking. And this person is very ill. So what I'm going to do is we are going to admit the patient. We are going to admit the patient in admitted in ICU where the person has some electrolyte imbalances. Please concentrate. Whenever there is an electrolyte imbalance or is not getting adequate amount of oxygen, hypoxemia, and very importantly, if the person is catheterized, okay, 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 decreased urine output or fecal passage of stools can again increase the precipitated. And very importantly, any medications that you are given. So for example, all of you could have seen that a person, because all of you would have trained in your MBBS, where a person comes to OPC poisoning, you give atropine. What is atropine? Anticholinergic, which will medications if you give in an ICU patient, which will increase the risk of precipitate delirium. And very importantly, any substance withdrawal. What is substance withdrawal? Like as a psychiatrist, I'm more concerned about. Anybody can answer this. Alcohol, the two after 72 hours of last drink, can precipitate the onset of delirium. Can precipitate the onset of delirium. Are you all with me, friends? Are you all with me, friends? I am going to repeat again. Please concentrate with me. This question is just to know whether you have an idea to diagnose delirium and also have some idea of the pathology of delirium. So delirium is nothing but the person is having altered sensorium, clouding of consciousness, disorientation, time, place, and person, and there is attention concentration impairment, and there is also got as acute confusion state and visual hallucination. So with this clinical scenario, you'll be able to diagnose delirium. Next, what you should know: depression deals with serotonin, schizophrenia deals with dopamine, and delirium deals with acetylcholine. See, this is all some 40 years, 30 years before the research. Okay, serotonin is the one which is related with depression, dopamine is one which is for psychosis, and acetylcholine is for delirium. Now there is a number of neurotransmitters. We have normal neurotransmitters, we have endocannabinoids, we have exonoids. There is a number of things, but the examiners who are going to sit for your paper, who frame the paper, are morely like 60 65 years old, where they were mainly working with serotonin, dopamine, and acetylcholine. So they will give importance to these basic neurotransmitters. Now, if you ask me what are the predisposing factors for delirium, I would say old male substance using dementia patient who's not mobile, who's having visual or auditory impairment. This person, what are the things for this person? What will precipitate the onset of delirium is that any brain insult. Here, there's a meningitis, any CCF failure, any pulmonary pathology, who's admitted in ICU, who's having electrolyte imbalances or hypoxemia, who's catheterized, is urine or fecal output is less. Is he on any medications which will decrease acetylcholine? And very importantly, substance withdrawal. As a psychiatrist, I'm very much concentrated on alcohol stopping within 72 hours of the last drink. Yes, friends. Next, we'll go to the second question. A 78-year-old male was brought by his son with complaints of bugs crawling all over his body. There is bugs crawling all over his body. He's okay. He speaks anything in front of anybody, which becomes hurtful and embarrassing. Social etiquette is lost. Very good. It is associated with forgetfulness. Memory is lost. He often forgets his way back home. He has Parkinson-like features. A brain biopsy shows the following. Actually, it's more like a pathology question. They are showing what is this body, okay, the image. Okay, the answer is Lewy bodies. Okay, now without, no sir, I'm not that much, I'm not the most hating subject that I had in my life, IFF is pathology, sir. I do not know this such, I've never opened Robin's book in my UG, sir. Even in that case, if you have just understood the question where a person is having forgetfulness, that is memory problems, Parkinson like features, and bugs, complaints of bugs crawling all over his body. He's seen something. Okay. Okay. It's nothing but a dementia with Lewy bodies. I'll just explain this. Please concentrate here. Please concentrate here. See, dementia with Lewy bodies is a very favorite for examiners. So I wanted to concentrate here. See, dementia, the difference between dementia and delirium is, already I've told you something about delirium, right? So dementia, difference between dementia and delirium is, here, the person will have altered sensorium. Here, it will be normal sensorium. Here, the person will have visual hallucination. Here, there will be not that much of visual hallucinations. No. Okay, this is the rule. We have some rules in psychiatry, right? And there will be some exceptions. The only disorder does not follow this dementia rule that the person should have normal sensorium and no have visual hallucination is dementia with the Lewy bodies. Why, sir? The points that I'm going to say, please concentrate. Please concentrate. This is a only dementia which has altered sensory. It is a only dementia. There's only dementia which has visual hallucination. It has extra pyramidal or Parkinson symptoms. And because of this, they'll be more sensitive. They are sensitive to antipsychotics. They have REM sleep disturbances, and very importantly, they have Capgras syndrome. What is this Capgras syndrome? I think by this time you should all know. Capgras is nothing but it's a delusion of double. Delusion of double. What do you mean by Capgras syndrome? There is actually two delusion of doubles. One is Capgras, another is free poly. I always tell my friends, don't read both. You'll get confused in the exam. Read only Capgras. What do you mean by Capgras? Capgras is nothing but a familiar person, please concentrate, familiar person is replaced by a non-familiar person, or a familiar person is replaced by a ghost, or a familiar person is replaced by a ghost. Okay, all this favors towards Capgras syndrome. If the question, if this is opposite, non-familiar person is replaced by familiar person, then go for frequently. Read just Capgras, read it by heart, and when the question is opposite, you will be able to change it. Okay, so I want you to just concentrate here. If you have read the question now, okay, there is visual hallucination, Parkinson like features, dementia. What is it? Dementia with Lewy bodies. Don't even know the need to know the pathology here. I'll just repeat here. Please concentrate. The normal dictum is in delirium there will be altered sensorium, in dementia there will be normal sensorium. In delirium, there is visual hallucinations. Dementia, there will be no visual hallucinations. But one dementia which does not follow this rule, where there will be altered sensorium, visual hallucinations, and there will be extrapyramidal symptoms. As there is extrapyramidal symptoms, they are sensitive to antipsychotics, and REM sleep behavioral disturbances and Capgras syndrome is dementia with Lewy. Now, an additional point, what is Capgras syndrome? It is nothing but delusion of doubles. It is Capgras and Frigoli. Please don't read Frigoli. Read only Capgras. Familiar person is replaced by a non-familiar person. Indian textbook says that familiar person is replaced by ghost. Standard textbook says that familiar person is replaced by imposter. Yes, friends? Yes, friends? My God, this definitely makes us very much panicked, but don't worry, I'll make it as easy as possible. A 19-year-old woman is brought to the physician by her parents because of irritable mood. There is irritable mood that started 5 days ago. Very good. Since then, she has been staying up late at night working on a secret project. Okay, sleep is She's energetic despite sleeping less than 4 hours per day. Her parents report that she is easily distracted. She is usually very responsible, but this week she spent her paycheck on supplies of her project. She has never had similar symptoms before. Very good. In the past, she had episode where she felt too fatigued. Please concentrate here. Too fatigued to go to school and slept until 2 p.m. every day for 2 weeks at a time. During those times, her parents noticed that she cried excessively and was very indecisive, expressed feelings of worthlessness. 2 months ago, she had an asthma exacerbation, was treated on bronchodilators and steroids. She tried cocaine once in high school but has not used it since. Vital signs are within normal limits. On mental state examination, she is irritable but cooperative. Her speech is pressured and her thought process linear. So the following is most likely diagnosis. So I've made sure that to understand this two pictures, the yellow means the person is very happy. Red means the person is very sad. What does it describe? What does it describe? Anybody? Anybody? You should be able to answer now. Please concentrate. Please concentrate. Before going to the answer, I'll just describe and then I'll go so that you'll be able to answer. There are two types of bipolar disorders. Okay, there are many types, but for exam, at least you have to know about bipolar 1 and bipolar 2. What is the bipolar 1? A person who's having mania, okay, mania and depression is called as bipolar 1. Okay, now what is the duration criteria for depression? You know that it is 14 days, and the duration criteria for mania is 7 days. Now, what is bipolar 2, sir? Bipolar 2 is nothing but a person is having hypomania. Hypomania. Hypomania is how long, sir? What is the duration criteria for hypomania, sir? 4 days. 4 days. And there will be a depression episode. There will be a depression episode. Now, this is called as bipolar 1, bipolar. Yes, yes. With this knowledge, it's more than enough for you to answer that a person has one depression episode and a mania episode. You call it as bipolar 1. Please concentrate. I want you to concentrate. A person is having one depression episode and one and mania episode. You call it as bipolar 1. And a person is having depression episode and hypomania episode. You call it as bipolar 2. Yes. Now, when you read the question, okay, the person is having hypomania like symptoms and also depression like symptoms. So it is naturally answered as bipolar 2. Now to further explain how a person, what are symptoms of mania? Okay, I'll always explain people about mania and depression side by side. Okay, because it will be easy to understand. Okay, depression and mania. In depression, the person will have decreased mood or low mood. Okay, in mania, you will have elated mood. In depression, the person will have anhedonia. Here, the person will have increased interest in pleasurable activities. What is anhedonia? Loss of interest in previously pleasurable activities. In depression, the person will have decreased energy level. Here, the person will have increased energy level. Here, the person will have decreased sleep, just insomnia. Here, the person will have decreased need for sleep. He's very happy, he's energetic, so he doesn't need sleep. So, it is we call it as hyposomnia. And in depression, we have what is called as Varguat fold and omega sign. Okay, whereas here you will have flight of ideas and pressure of speech. Yeah. This is the difference between mania and depression. I think this is not going to be confusing. Next, you should know what is the difference between mania and hypomania. See, just one question: how long we can take the discussion? It's like Anumar's tale. Okay, you can take it for a long time. Okay. My mania, the duration criteria is 7 days. Hypomania is 4 days. Mania, you will have flight of ideas. Here we have ordered flight of ideas called as prolixity. Prolixity. Okay. Here there will be, sometimes it results in dysfunction. Here there will be no dysfunctionality. Dysfunction. Another one point which most of my friends ask, sir, a person comes with depression now, sir. A person comes with depression now. How do I know? How do I know this is just one pole, unipolar depression, or how do I know that this person is a propensity to go into mania? We call it as unipolar depression, and this is bipolar depression. How do I know that this is unipolar depression or bipolar depression? Because if there's a past history of mania, I can ask an history. But here, what is the chance that they might get a mania? Can I get it in the history? Yes. Please concentrate on this diagram. Please concentrate on this diagram. A person who has, okay, is only having depression. There is no mania. So who's having, what is this? Abrupt onset. Multiple episodes. Small episodes. Okay. And in the episode, the person will have atypical symptoms. What is atypical symptoms? Increased sleep, increased appetite. Okay. The person will have psychotic symptoms. The person has onset postpartum. Postpartum depression is more likely to be bipolar. Postpartum. And when I get a family history, there will be family history of bipolarity. Okay, these questions, these we call it as specifiers. We call it as when you go for, if you have spent time with psychiatry case presentations, when they are presenting about depression, they will say, what are the bipolar specifiers? There is multiple episodes. Okay, it starts at a very early age. Okay, early age, multiple episodes, abrupt onset, small episodes with increased psychomotor retardation. If there is any psychotic symptoms, if there is a postpartum onset, if there is a family history of bipolar, we call it as bipolar specifiers, where you know that this depression can go into, or you can expect a mania in this patient. Yeah. So it's a very nice, interesting question. So with this knowledge, if you read this question, a 19-year-old female, she's having irritable mood, staying up late at night. So this is hyposomnia despite sleeping less than 4 days a day, and she's increased involvement plus black days. This is hypomania. She's too fatigued, very indecisive, worthless, hopeless, helpless, worthless, and also it's nothing but depression. Depression and hypomania is called as bipolar. With that itself, you'll be able to clarify. So I'll just have given some extra points, so I think it will be useful for you. Mania and depression is bipolar 1. Hypomania with depression is bipolar 2. Difference is 4 days and 7 days, the duration criteria. Okay. How will you differentiate between depression and mania? It's very simple. Common sense. Decreased mood, here increase elated mood. Here it is anhedonia, here it is increased interest in pleasurable activities. In depression, there is decreased energy. In mania, there is increased energy. In depression, there is decreased sleep. I want to sleep, but I'm not getting sleep. That is insomnia. In mania, though I sleep for 2 or 3 hours, it's enough for me. I'll be active. That is increased need for sleep. And very importantly, here there is a Bhagavad pole and omega sign, whereas in mania, we'll have flight of ideas and pressure. So how to differentiate between mania and hypomania, sir? That's again a different, very interesting question. Duration criteria is 7 days and 4 days. Here you will have flight of ideas, here you will have prolixity, and there in mania you will have dysfunction, whereas in hypomania you don't have any socio-occupational dysfunction. So how do I know that a person depression present in me? Okay, if there is mania history, you will say that yes sir, I had one episode. That's why always I ask a question for a person who's coming with depression. Sir, yes sir, I can accept that you're feeling low, sad, worried and depressed, as have we experienced any opposite symptoms? If they say no, then it's obvious that no, that it's not more bipolar. But what is the chance that the person might not get a mania later? Okay, so we are not sure how to know it. Does that there are some specifiers where early age of onset, abrupt episode, multiple episodes, smaller episodes, and family history of bipolarity, atypical symptoms like increased sleep and increased appetite with psychotic and postpartum onset. Again, another big question. A 25-year-old college student comes to the physician because of left knee pain. Pain started that when he fell off his bike 1 year ago. Since then, he had intermittently stabbing pain and tingling in his knee. The patient says that the pain is caused by a device that is implanted by the US government to control his thoughts and actions. He says it was also responsible for the bicycle accident. For the past 6 months, it has caused him to hear voices telling him there is hearing voices. He does not listen to their commands because he does not want to play by their rules. He has avoided meeting his family and friends since the voices started. Very good. Vital signs are normal. Left knee is non-erythematous, no swelling. Range of motion is normal. Neurological is no normal and appears expressionless. Which of the following? So what are they talking about? What are they talking about? A person is having a person is having auditory hallucinations, is having delusion, duration criteria of 6 months. What are they asking? They are asking about schizophrenia. What is the first line? What is the first line of treatment? Always you should give antipsychotics. What are the antipsychotics? Any idea about the antipsychotics? You should know that the answer here is I would go for QTAPN. Why am I going to this answer? I'll tell you. No, the antipsychotics, okay, can be divided into two. Okay, what is this? First generation antipsychotics or second generation antipsychotics. First generation is also called as typical antipsychotics. Second generation is also called as atypical antipsychotics. Typical antipsychotics is also called as dopamine antagonist, and second generation is called as serotonin dopamine. Nowadays, it's always because these first generation has a lot of side effects. We always go for the newer drugs, second generation antipsychotics, among which most commonly prescribed is we have something called as, I think they'll teach you in this pharmacology lesson, risperidone, okay, olanzapine, QTAPN. So the choice is QTAPN. So there is another drug which is clozapine, which is a very favorite part of examiners. Why did you choose the drug? I'm going to explain that to you. Clozapine is a drug, okay, which is a drug which is a first second generation antipsychotic. It is anti-suicidal. It is used for treatment resistant schizophrenia. What do you mean by that? A person fails. A person fails two antipsychotics. When a person fails two antipsychotics, then you start the patient on clozapine. Why, sir, I should wait for two antipsychotics to fail? Why don't I use it as the first drug? Because there are problems, life-threatening side effects like agranulocytosis, myocarditis, seizures, and paralytic. These are life-threatening. Sir, is there any common side effects, sir? Yes, you have some common side effects like, what is this? Obesity, constipation, and very important complaint is this. Cyalo, Cyaluria. Yes, friends. Yes, friends. Please concentrate. Please concentrate. Here, the person is having only one very clear episode of schizophrenia is there. What is the antipsychotic you use? You will more the among the choices, the best choice is among the clozapine is not used because it's used only for treatment resistant schizophrenia. Sertraline is not used because it's an SSRI which is used for depression. Flufenazine is again first generation antipsychotics. Nowadays we are using more of second generation antipsychotics, so QTAP is a choice. So and a quick rush antipsychotics is of two types: first generation and second generation. First generation is also called as typical. Second generation is called as atypical. First generation is called as dopamine antagonist, and second generation is called as serotonin dopamine antagonist. What are the drugs? Risperidone, olanzapine, and QTAPN. Now, what do you know about clozapine? This is the question that has been asked in the recent INICET and NEET. So please concentrate. Second generation antipsychotic. It's anti-suicidal. This is used for treatment resistant schizophrenia. That is after two antipsychotics fail, then only you use clozapine. Why, sir? Because it has life-threatening side effects like agranulocytosis, myocarditis, seizures, and paralytic. Yes. Is there any common side effects, sir? Yes. Obesity, constipation, and cyaloria. Next question. A 25-year-old male student comes to the physician for a 2-month history of repeated thoughts of anxiety that he is going to be harmed by someone on the street. Okay, somebody is going to harm me. The anxiety person, after witnessing a pedestrian getting hit by a car 2 weeks ago, he says that this is a warning sign. On his way to school, he now often leaves an hour earlier to take a detour and hide from the people that he thinks might hurt him. He's burdened by his work and fears that his professors are meaning to fail him. The patient has no known history of psychiatric illness, and the mental state is alert and oriented and shows a full range of effect. Thought process and speech are organized. He says his friends are concerned about him, but they do not understand because they were not present at the accident. His memory and attention is within normal limits. He denies any hallucinations. Urine toxicology screen is negative. What is the diagnosis? I would go for the answer is delusional disorders. Why? I'll tell you the futures of delusional disorders, which will be able to answer it clearly. See, delusional disorders is nothing but a person, a person who's having a predominant delusion. What is delusion? A false, fixed, firm belief. Okay, it can be any belief. For here, if the person feels that somebody is against it. Now, this delusional disorders, hallucinations, okay, is not present or not common. Okay, outside the delusion, okay, if you remove the delusion, is functionality and social behavior is some seems to be normal. Okay, there is no thought process, there is no thought abnormalities. Okay, now there is a small confusing point here. What is the duration criteria for delusional disorders? Okay, please concentrate. When a delusional disorder question comes, and if all these features are met, please go for delusional disorders, because the delusional disorders, as you know, there are two classifications, DSM-5 and ICD-11, where DSM-5 says that the duration criteria for delusional disorders should be at least 1 month. Okay, whereas IC11 says 3 months. So there's a so don't go by the duration criteria for the diagnosis or answering this question. Go by what is called as the points which favors. Okay, because when a person is having schizophrenia, what should be there? Person will have delusions, auditory hallucinations, disorganized speech or behavior. The person is having schizotypal. This is again another choice was there. Schizotypal, okay, where the person will not have delusions or hallucinations, but they will have odd dressing, odd thoughts, magical thinking. This is a only personality that is classified both under personality disorder lesson and also schizophrenia lesson. Okay, these are all extra edge points, but with this question, I think you'll be able to answer. The person is having a fog fixed belief that people are going to harm him. There is no hallucinations. It's present more than around 2 months. So, what is the diagnosis? The answer is delusional disorders, because the points that you should consider is the delusion should be predominant. Life revolves around the delusion. Hallucination is not common. Outside the delusion, when you see, is totally normal, and there is no thought abnormalities. There is no thought abnormalities. Put across here. There is no thought abnormalities. Yes. Where don't go for the duration criteria, because in DSM-5 it is 1 month and ICD-11 it is 3 months. And what is the schizophrenia? Okay, if you have to go for schizophrenia, it is delusions, auditory hallucinations, and disorganized speech and behavior. Schizotype will have odd dressing, odd thoughts, and magical thinking. And this is the only disorder that is classified both under personality disorder lesson and also schizophrenia lesson. Wow, this is very easy. A 40-year-old man brought to OPD by his wife presented with a bald patch on the side of his head, non-scarring, yes, hair growing of different lengths, and an otherwise normal physical laboratory examination. An image of the patient is given. What is the diagnosis? Answer is naturally, answer should be trichotillomania. Okay, because hair, there's a bald patch and there's not scarring and there is hair of different lengths. That is a characteristic feature of trichotillomania. I'll just concentrate here. Please concentrate here. It's very, very important. Trichotillomania. Okay. What is the other name for trichotillomania? They ask this question, what you will say? Sir, it is called as hair pulling disorder. Sir, What is the change in the DSM-5 classification? It is now classified under obsessive compulsive spectrum or related disorders. Trichotillomania, hair pulling disorder. Sir, where do they? What is the most common site, sir? The site will be most commonly from the skull. Second site will be the eyebrows. By looking at the skull, will you be able to say something, sir? Local examination. Hair, which is of different length, okay, and different growth size. Because you pull one hair, okay, the other hair would be normal, and the pulled hair from there will be new hair that will be growing. So there is a local examination in the scalp that will be done. And very important point that I will always tell friends to remember is, see, when you pull the hair and you put it down, you call it as trichotillomania. But if you pull the hair and also you eat it, okay, you call it as trichophagia. You pull the air and you eat it, but this is going to cause some intestinal obstruction. It's called as trichobazar, also called as Rapunzel syndrome. Okay. Okay, you know this fairy tale where there is a long hair. Now this is a very surgical emergency. This is a very important surgical emergency where they'll ask you on surgical questions. What is the treatment? Okay, treatment for hair pulling disorder is habit reversal training. Any other mode of treatment available? SSRIs. Okay, SSRIs. I'm very much like what to say, attracted towards trichotillomania because it's often asked and it's very important for students to know about this disorder. Okay, so I'll just repeat. Please concentrate. Okay, a person with trichotillomania, the other name is hair pulling disorder. Where it is classified in DSM-5, it is classified in obsessive compulsive related or spectrum disorders. Where is the most common site? Scalp, and second is eyebrows. What is the local thing? Different length of hair will be there and different growth pattern will be present. When you just pull the air, it's trichotillomania. Pull the air and eat it, it's trichophagia. Pull the air, eat it, and obstruction, it is called trichobazar or Rapunzel syndrome. It's a surgical question. What is the treatment? Habit reversal training and SSRIs and SSRIs. Next, a 25-year-old man complains of excessive sleepiness during the daytime for years despite adequate nighttime sleep. Okay. He has sought medical attention after falling asleep while driving. When he is awake, he is falling asleep. He's slender, otherwise healthy. He's slender, otherwise healthy, and on no medications. Which of the following symptoms you might also complain about? Okay. See, always I ask students, you can answer a question on two areas. Either you can go for which of the following is the best. If you know what they are asking about, you can go and search for it. Otherwise, see other choices. It might be going towards one diagnosis. Here, the answer is excessive snoring, automatic behavior, restless sleep, and morning headache. Now, to be frank, if you have known about these choices, this excessive snoring, restless sleep, and morning headache goes hand in hand with obstructive sleep apnea. And the disorder that they are explaining, where the person is not obese, he's slender, he's having excessive sleepiness, daytime sleepiness, and falling asleep. When he's awake, he's while driving, he's sleeping. So this is nothing but cataplexy, and this is nothing but daytime drowsiness. And they are talking about narcolepsy, where you will have automatic behaviors. So answer is automatic. I just put some words important for our narcolepsy because it might be asked. Narcolepsy. Okay. Narcolepsy is not characterized by cataplexy. Please concentrate. Cataplexy. What is cataplexy? Sudden loss of tone when he's awake and he goes to sleep. That's in the question. Then the person will have hypnagogic hallucinations. Hallucination. But hypnagogic means while going to sleep. While going to sleep, you will have hallucinations. Then you will have hypnopompic hallucinations. Then you will have daytime drowsiness. Then you will have sleep paralysis, automatic. And one of the newer advances, automatic. That is, a person seems to act like does a purpose, seems to be a purposeful movement, but is not aware of it. That is automatism, automatic. Okay, like an automatic gear. Okay, automatism. Now, another important question that is asked in narcolepsy, I would like to concentrate is, what deficiency causes narcolepsy? Anybody? Hypocretin or orexin? What is the test that you do? MSLT. What do you mean by this? Multiple sleep latency test, or MWT, maintenance of wakefulness test, which all shows that the person gets the sleep where normally a person will get will go to lie on bed, mind wandering, eyes closed, non-REM and REM. But the basic mechanism here is that REM spillage, or REM comes early. That is called as reduced REM latency. These are the various points that you should know under narcolepsy. Narcolepsy is a very, 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 very favorite point for examiners. Okay, the only sleep disorder that I spend nearly 20 minutes for description or discussing is narcolepsy, because I feel that examiners love this topic. When an examiner respects some topic, as a student, we should also respect that topic. Okay, so please concentrate here. What are they talking about narcolepsy? Narcolepsy is nothing but the person will have cataplexy. What do you mean by cataplexy? It's sudden loss of muscle and goes to sleep. Hypnagogic hallucinations, hypnopompic hallucinations, they will have increased daytime drowsiness, sleep paralysis, and automatism. What deficiency causes it? Hypocretin and orexins. What is the test that you do? Multiple sleep latency test and maintenance of wakefulness test. What are you looking into it? Whether REM is coming in unwanted places, REM spillage or reduced REM latency. REM comes earlier than what it is needed. Now, the eighth question. A 72-year-old male with chief complaint of memory loss, inability to find appropriate words during conversation. He seems to be lost in his own thoughts. He doesn't respond to his family members. So there is a memory loss person. Okay. He's unable to do his daily course and often doesn't recognize people. Very good. So this is dementia. Yes. Yes. Very importantly, the person is having amnesia, agnosia is there. Okay. Executive dysfunction is there. So basically, this is dementia. Which drug cannot be given in this condition? There's something called as donepezil, rivastigmine, memantine, and benzotrofen. Out of the box is benzotrofen. You don't need anything about, need not even know what is the diagnosis. If you know what is the treatment for dementia, we have about the question called as, I always tell a mnemonic for students, mega do rita. What do you mean by this? Memantine, galantamine, donepezil, rivastigmine, and tacrolimus. What is the action of these drugs? Only memantine is an NMDA antagonist, whereas all others are acetylcholine esterase inhibitors. What are they trying to say about this? Basically, what happens is that what they're trying to say is, normally acetylcholine is needed for memory. This acetylcholine will be degraded by enzyme called as acetylcholine esterase. Now, already the person is having dementia, his memory is degrading. Okay, now the remaining acetylcholine at least should be prevented from the degrading. So what happens is that normally the acetylcholine esterase, okay, will engulf acetylcholine. So when I give a drug acetylcholine esterase inhibitor, which will prevent this enzyme. So less amount of acetylcholine will be still available, which will help in, what to say, slower the disease. And again telling you all these, friends, all these disorders, okay, these drugs which help and delay the progression of the illness, doesn't reverse. So memantine, galantamine, donepezil, robastamin, and tecren. If you just know this table, you could have answered, because donepezil, robastamin, and memantine are anti-dementia drugs. Benztropine, okay, I just want you to concentrate. Benztropine is a drug which is used for, again in psychiatry, it's used for dystonia and extrapyramidal symptoms or Parkinson's symptoms, which is nothing but it's an anticholinergic. See, already I'm saying acetylcholine, lesser amount of acetylcholine is there. This acetylcholine is helpful for memory. I'm giving it, the drug is benztropine is an anticholinergic. So when the lesser amount of acetylcholine is also going to be ranged, naturally what happens? It will worsen the dementia. It's just a pharmacology basis will be able to answer this question. I'll always tell my friends, please read reversible cause of dementia, because INICET has asked. So vitamin B1 deficiency, vitamin B12 deficiency, and niacin deficiency, normal pressure hydrocephalus. There is once a question called as a person is having dementia with, what is the triad of normal pressure hydrocephalus? Anybody can tell me? Dementia with ataxia with incontinence. Don't think that I'm including too many points. All are important points. All are recent MCQs. And very importantly, they will have hypothyroidism. Okay, if a person is, that's why whenever a person comes with dementia, I will always ask for a nutritional panel to see whether there is vitamin B1, B12, or niacin deficient. I will ask for MRI brain to see whether there is normal pressure hydrocephalus. I will ask for thyroid function test to see whether it's hypothyroidism. Because if any of this is diagnosed, I'll be happy, patient can be happy, patient family members can be happy, because it's 100% reversible. Otherwise, if it's irreversible dementia, I can only delay the progression by using the drugs called as megadorita. What is megadorita? What is megadorita? Memantine, galantamine, donepezil, robastamin, and tacrin. Memantine, the NMT antagonist. Whereas all other drugs are acetylcholine esterase inhibitors, where acetylcholine should be preserved so that the disease doesn't progress in a faster manner. But benztropine, which is one of the choice, is actually an anticholinergic, so it will worsen the condition of dementia. Now, what are the reversible causes of dementia? Vitamin B1 deficiency, B12 deficiency, niacin deficiency, normal pressure hydrocephalus, and hypothyroidism. Now, the last but one question. A 21-year-old man comes to the physician because he believes that he has low testosterone. Okay, low testosterone. He states that he is embarrassed at his lack of musculature. Very good. Despite lifting weights twice daily. Every day he drinks 2 glasses of milk and several protein shakes in addition to large meals. He's convinced that his female classmates at the community college he attends are secretly laughing at his scrawny appearance. He has attended fewer and fewer classes out of embarrassment and shame. He's also concerned that his hair is thinning and applies topical minoxidil to his scalp 3 times daily. He spends 2 hours daily anxiously examining himself in the mirror. Wow, this is a characteristic picture. Examining himself in the mirror. He's wearing long sleeve shirt and a hat. Very good. His BMI is 26. Physical examination shows abnormalities. On MSc, he's anxious and she's normal testosterone. What is the answer? Okay, this might sound something difficult, but the answer is body dysmorphic disorder. Sir, why you have given the diagnosis of body dysmorphic disorder? I'll explain body dysmorphic disorder. If I explain, you'll be able to get it. Know why am I saying? First of all, what do you mean by body dysmorphic disorder? What is the other name, sir? Other name is, anybody? Dysmorphophobia. Dysmorphophobia. Yes, 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 yes. What is, who introduced this history? In nearly around 1880s, there was a person called as Morselli who introduced about body dysmorphic disorder, dysmorphophobia. What is the classification? Now it is classified under obsessive compulsive spectrum or related disorders. What is the most common complaints of the person feels that he has a defect. He has a defect. What is a defect? It can be either a shape of a nose or a jawline, or the person may complain that there is a problem with the hair, okay, length or thickness or quality, okay, or it will be like a skin color. Okay, skin color. I'm not fair enough, or I'm not, my skin is very dark, so skin color. They worry about that they have a defect. Okay, and because of this worry of the defect, what they will do is, what is another important point is, they have continuously, okay, have mirror gazing. They'll be keep on looking into the mirror and confirming it whether what they are believing is true, or check whether like it's fine. And they will have covering up behaviors, like as given in the questions, where they'll have a very big hat, or they'll be having a very big, like a full sleeve shirt, covering up behaviors. Okay. Covering up behavior. Yes, 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 yes. This is nothing what you should know about body dysmorphic disorder, okay, or dysmorphophobia. There is a newer entity. There is a newer entity called as muscle dysmorphophobia, where a person feels that though, okay, is having is of average weight, or is having good amount of muscle, they feel that they are lean. Okay, they feel that they are lean, and they're very concerned about their physical appearance, or having a good amount of musculature to attract the people. Okay, so please concentrate. If you just know that there is an entity, okay, called as dysmorphophobia. Okay, there's an entity called as dysmorphophobia, which was given by Moseley, where it is classified under obsessive compulsive related disorder, where they will mainly have problem with defects. Okay, hair, skin, or there's a newer advanced called as muscle. Okay, where they will have continuous mirror gazing, and they'll covering up behaviors. We call it as body dysmorphophobia or dysmorphic disorder. If you know this entity, there is no chance of confusion, because all the thing that I've described now is put in this question. Just show a green color for all that. See, there is a lack of musculature. Yes, there's a point. Yes, he's lifting weights daily. Okay, now he's taking some more amount of milkshake, protein shakes, and all that. Okay, now he's having embarrassment and shame. Okay, he feels that he's having some defect. Now, what happens is that his hair is thinning. He's examining himself in the mirror, okay, checking, and wearing a long sleeve shirt, covering up. So, whatever I've explained there, every point is put here, so it is more favorable towards body dysmorphic disorder. Body dysmorphic disorder. The last point, a 38-year-old woman is brought to the physician by her husband because she cries frequently, refuses to go out of bed. Over the past 3 weeks, she has been feeling sad and tired most of the time. Very good. She has difficulty staying asleep at night and often wakes up early in the morning. Very good. Early morning awakening. After losing her job as a nurse 1 month ago, she has been feeling guilty for not contributing to the household income. Very good. She is diagnosed with anorexia nervosa at the age of 18 and has gone to psychotherapy several times since then. Her weight has been stable for the past 5 years. However, within the past 3 weeks, she has had a 3 kg weight loss. She had desire to regain some weight. Physical examination shows no abnormalities. Mental state examination shows a depressed mood and flat affect. There is no evidence of suicidal ideation. Which of the following is most likely to address both the patient's mood disorder and her desire to gain weight? Wow. Okay, I'll just explain this and I'll then come to the answer. Okay, the person is, what is the person is having low, the patient is having low mood. Yes, yes. Decreased energy, decreased appetite, because of which there is a decreased weight, worthless, guilty, and hopeless. Yes, decreased sleep, early morning awakening is there. So it's mainly depression. So you have to treat depression. Now, this person, is there any past episode of mania? No past episode of mania. No bipolarity. No bipolarity is there. Very good. Okay. So, what is the drug you will use? So they have the question is, what is the antidepressant or what is the drug which will increase the weight of the person and also acts as an antidepressant? Lithium is not an antidepressant, it's a mood stabilizer. Leave it. Okay. Okay. Now there are only three drugs, which is fluoxetine, metrazapine, and phenylizine. Okay. Good idea about this will help you to answer these questions. See, MAOIs. Okay, one of the drug under MAOIs is phenylizine. Yes. Now this drug, okay, will increase the weight of the patient, but it can cause cheese reaction or hypertensive crisis. Okay, so you need not choose it as a first line drug. Next, we have something called as SSRIs, like fluoxetine, which will actually research says it can either increase weight or decrease weight of the patient. Increase weight or decrease weight of the patient. So you don't want to use this drug. Okay, this I'm not using because of cheese reaction. This I'm not using because as it might either increase or decrease the weight of the patient. Next comes NASA, noradrenergic specific serotonergic antidepressant. This is nothing but mirtazapine. Okay, I always tell my friends there are three one words. Okay, what is the use? It will increase the weight of the patient. Increase the weight of the patient. Okay, it will improve the sleep. In good amount of sleep will be better. Okay, but thing is that it can cause dyslipidemia or hyperlipidemia. Dyslipidemia. That's a problem. So basically, what are they asking is dyslipidemia. Okay, so what are they asking is what is the drug which will have both increase in weight of the patient and also as well as it's an antidepressant, and this what is the best choice that is available as this person is having both depression and also he needs to increase weight. The first line of drug will be mirtazapine, which is a NASA, which will increase the weight of the patient, improve the sleep of the patient, and but only problem is they'll have dyslipidemia. MAO is though phenylizine is a drug, it has cheese reaction or hypertensive crisis, which is a psychiatric emergency. So don't go it as a first line drug. SSRIs can be used, but the thing is that it can either increase or decrease the weight of the patient. Where our agenda is to increase the weight also, so it's not the first line of drug. So I would go for mirtazapine. I would go for mirtazapine. Yes, yes, friends. Yes, friends. Good, good, good. I think it's a wonderful discussion that we had because I basically feel that clinical scenario questions gives me a kick. Because if there is a question like, what is the drug which causes priapism in psychiatry? Trazodone. What is the drug which is used for what is it? Premature ejaculation? Answer is depoxetin. Okay, one-liners just checks your memory. Okay, but as a person who loves psychiatry, as a person who loves the concepts in psychiatry, as a person who understands the clinical symptoms of psychiatry, and as a person who desires that you should all know about the concepts, I basically love that clinical related questions because it gives you a kick. Okay, whenever there is a pain or when life is hard and you face a success or taste success, it gives you a kick. So when there's a clinical related question, you just try to catch on the points and then come to answer, and you feel that it is right. It gives you a kick. So I basically I was very happy when the Google team approached about the clinical related discussion video. So I hope that it was of some use for you because we had a lot of discussion related to the topic. I always advise friends, whenever you read a question, read PYQ question, read related topics because that's where the questions will be asked in the subsequent papers. It was a wonderful experience because we had this INICET, okay, recall. We did it in like what to say March end or April, and the pre-VQ discussion, and after the exams we just opened and saw the uh, like what to say PYQ videos where I used to tell the question answer and the topic related. We had nearly 7 to 8 questions which was repeated. Okay, it was like mind blowing. It was an eye opener. So I think you should all be very much careful and always read the one liners, read the contents, read the concepts, plus read the PYQ related topics. Related topics. Don't, you need not read the whole psychiatry. Okay, because nobody's going to give you a what is it like what is it third year MD degree certificate. They're not going to give you. You're going to just enter into the PG, read the topics which is related to the PYQs, give more importance, more spend times on the PYQ related topics, which will help you to get marks. Whenever there is a clinical related questions, please rely on your knowledge on concepts. Yes, friends. So thank you for your valuable time. We'll meet soon. Love you all. Take care. Bye bye.